All right, so welcome back, everyone. We're going to pick up right where we left off on page 1293 under changes in the gastrointestinal system. Looking under anatomy and physiology, it says changes in the mouth include a reduction in the volume of saliva with a resulting dryness of the mouth. Blood flow to the liver declines and enzyme activity decreases. And under pathophysiology, there are specific GI problems that are more common in older patients, which include diverticulitis, bleeding in upper and lower GI system, peptic ulcer disease, gallbladder disease, bowel obstruction, and diverticulosis. And if you'll look under on page 1293, right-hand side, third paragraph, go ahead and highlight those. And also, where it says upper gastrointestinal bleeding occurs in esophagus, stomach, and duodenum. These bleeding episodes are sometimes seen in people who are long-term users of non-steroidal anti-inflammatory drugs, or people who are long-term alcohol users. Go ahead and highlight that. Excuse me. All right. Also, under the definition of peptic ulcer disease, go ahead and highlight that. All right, the acute abdomen, page 1294. Non-gastrointestinal complaints. In the pre-hospital setting, the most serious threats from abdominal complaints is blood loss, which can lead to shock and death. Abdominal aortic aneurysm is one of the most rapidly fatal conditions, and that definition, go ahead and highlight that. The bottom of page 1294. And we'll move along to changes in the renal system, also on page 1294. Anatomy and physiology, age-related changes to the kidney include a reduction in renal function, a reduction in renal blood flow. Changes in the urinary system include decreased bladder capacity, decline in sphincter muscle control, decline in voiding senses, increase in nocturnal voiding, and benign prostate hypertrophy, which is an enlarged prostate. Under pathophysiology, we see acute illnesses in older patients is often accompanied by derangements in fluid and electrolyte imbalance. Incontinence is not a normal part of aging and can lead to skin irritation, skin breakdown, and urinary tract infections, or basically UTIs. The opposite of incontinence is urinary retention or difficulty urinating. Bladder and urinary tract infections can also cause inflammation, and in severe cases of urinary retention, patients may also experience renal failure. All right, page 1295. Under anatomy and physiology, a significant change that occurs in an older person is decreased metabolism of thyroxine, a condition called hyperthyroidism. Thyroxine affects the body's metabolism, temperature, growth, and heart rate. All right, most of the signs and symptoms people experience are attributed to the process of aging and include a slower heart rate, fatigue, drier skin and hair, cold intolerance, and weight gain. Looking at pathophysiology, we see that hypersmolar hyperglycemic nephrotic syndrome, or HHNS, is a diabetic complication in older people that occurs more often in people with type 2 diabetes. The signs and symptoms of HHNS and diabetic ketoacidosis, they often overlap. Assessment findings in patients with HHNS include a glucose reading of higher than 600, polyuria, which is increased need to urinate often. Polydipsia is the feeling of extreme thirstiness. They could be dehydrated, they could have fever, fatigue, mental status change, which includes confusion and seizures. And the patient may present with signs and symptoms of hypotension and shock, including tachycardia. Now, symptoms assessment findings in patients with DKA include polydipsia, polyuria, nausea and vomiting, weakness or fatigue, shortness of breath or rapid deep breathing, hyperventilation, they'll have fruity scented breath, confusion, and it also have hot dry skin. So you'll see the signs and symptoms are pretty much the same, except the biggest difference between DKA and HHNS are blood glucose levels will be variable in DKA, where in HHNS the value is typically 500 or higher. DKA will also present with what is called Kussmaul's respirations, while HHNS will not, and also people in DKA will have fruit-scented breath. And to me, it smells like a person who is chewing juicy fruit gum. So looking under pathophysiology, go ahead and highlight that first paragraph. And it's very important that you know the difference between DKA and HHNS for National Registry, because you will see that on National Registry. All right, changes in the immune system. Infections are commonly seen in older people because they are generally have an increased infection and are less able to fight infections once they occur. Many older patients may be unable to develop a fever, and in fact may be hypothermic as a manifestation of severe systematic infection. Fatigue, weight loss, falls, or changes in mental status may be the primary symptom of an infection. Pneumonia and a UTI are commonly seen in patients who are bedridden, and when infection occurs, signs and symptoms may be decreased or minimized by the patient. All right, 1296, changes in the musculoskeletal system. Under anatomy and physiology, aging brings a widespread decrease in bone mass in men and women, but especially among premenopausal women. So bones may become more brittle and tend to break more easily. The disc between the vertebrae and the spine begin to narrow, and a decrease in height of 2 to 3 inches may occur through the lifespan, along with changes in posture. Joints lose their flexibility and may further immobilize by arthritic changes, and a decrease in the amount of muscle mass often results in less strength. All right, under pathophysiology, changes in physical abilities can affect an older person's confidence and their mobility. Their strength declines, and ligaments and cartilage of the joints may lose their elasticity. The stoop posture of older people comes from atrophy of the supporting structures of the bone. And if you look under the definition of kyphosis, where it starts with the stoop posture of older people, all the way to the definition, go ahead and highlight that. All right, osteoporosis causes a decrease in bone mass, leading to reduction in bone strength and greater susceptibility to fracture. Osteoarthritis is a progressive disease of the joints that destroys cartilage and promotes formation of bone spurs in joints and leads to joint stiffness. All right, changes in skin. The proteins that make the skin pliable decline with age. The layer of fat on the skin also becomes thinner because of redistribution of fluids and protein. As the elasticity of skin declines, bruising becomes more common because the skin can tear more easily. Skin tears lead to infection, which can eventually lead to sepsis. Exocrine glands or sweat glands do not respond as readily to heat because atrophy and change to the tissue of the dermal layer of the skin. Pressure ulcers, or commonly called bed sores, or debutus ulcers. The pressure from the weight of the body cuts off blood flow to the area of skin, causing sores to develop. And page 1287 on toxicology. Older people are more susceptible to toxicity because of decreased kidney function, altered GI absorption, and decreased vascular flow in the liver. All right, under behavioral emergencies, page 1298. We'll talk about depression. Depression is not a normal part of normal aging, rather it is a medical disease. If depression goes unrecognized or untreated, it is associated with a higher suicide rate in the geriatric population than any other age group. And if you look at on page 1299, the last paragraph where it says it's possible to predict which older adults have depression, but studies indicate that substance abuse, isolation, prescription medication use, chronic medical conditions all contribute to the onset of significant depression. Go ahead and highlight that. And we'll move on down to suicide. Most older adult suicide victims have recently been diagnosed with depression and have seen their primary care physician within a month before the event. Older men have the highest suicide rate of any age group in the United States. And on the second paragraph where it says suicide rate among older Caucasian men is almost twice the rate of all other male groups. The highest risk are white male 85 years and older who use firearms as a suicide method of choice. Go ahead and highlight that. All right, when you assess the patient who's displaying signs of depression, go ahead and ask he or she if they have ever considered suicide. All right, on page 1299, the Jim's Diamond, I'm going to allow y'all to read that for yourself. And we'll move on over to special considerations in assessing a geriatric medical patient, page 1301. So challenges that you may encounter during this assessment include communication issues, hearing and vision deficits, alteration in consciousness, complicated medical history, and side effects of medication. All right, under your scene size up, geriatric patients are commonly found in their homes, retirement homes, or skilled nursing facilities. And you'll need to take note of any negative or unsafe environmental conditions. In any case in which patient's mental status is altered, you need to find someone who can tell you the patient's history and whether the patient behavior or level of consciousness is altered or whether it's normal. All right, under mechanism of injury, nature of illness, the NOI may be difficult to determine in older people who may have had an altered mental status or dementia. You must ask family member, caregiver, or bystander why he or she called. All right, under primary assessment, you always want to address life threats. Determine the transport priority of your patient based on his or her condition and maintain a high index of suspicion for serious injuries. As you approach the patient, you should be able to tell if the patient is generally in stable or unstable condition. So you want to use your APU scale to determine the patient's level of consciousness. All right, on the airway and breathing, aging and disease can compromise the patient's ability to protect his or her airway with the loss of a gag reflex and normal swallowing mechanisms. So you want to ensure a patient's airway is open and not obstructed by dentures, vomitus, fluid, or blood. Autonomic changes may also affect a person's ability to breathe effectively. Loss of mechanisms that protect the upper airway, such as cough and gag reflexes, cause a decreased ability to clear secretions. And airway and breathing issues should be treated with oxygen as soon as possible. All right, under circulation, poor perfusion is a serious issue in the older adult. Psychological changes may negatively affect circulation. You'll see lower heart rates and weaker and irregular pulse that are common in older patients. Vascular changes and circulatory compromise may make it difficult to feel a radial pulse in older patients. Circulation problems in older patients should be treated with oxygen as soon as possible, and you want to determine if cardiac abnormalities in an older patient indicate an acute emergency or chronic condition. All right, untransported decision. Patient assessment is more complicated in older adult, and multiple problems can exist. And any complaints that compromise airway, breathing, or circulation should result in transportation of the patient as a priority patient. And always remember that older people do not have the reserves that younger people do, and they will easily decompensate. So you want to consider early on if ALS treatment and immediate transport is appropriate and available. All right, under history taken under 1302, you always want to investigate the chief complaint. Find and account for all medications. Communication may be more complicated with an older adult, but it's critical that you obtain a thorough patient history and determine early on whether the altered level of consciousness is acute or chronic. Under sample history, you may have to rely on a relative or caregiver to help you in collecting a sample history. And you have to obtain a list of patients' medications or take the medication with you to the hospital if possible. All right, on secondary assessment, page 1303. Under physical examinations, your older patient may not be comfortable being exposed, so you always want to protect his or her modesty. And you want to consider the need to keep your patient warm during the exam. All right, under vital signs, medications such as beta blockers keep the heart rate low and prevent the tachycardia commonly seen in dehydration and shock. Weaker and irregular pulses are common in older patients. Circulatory compromise may make it difficult to feel a radial pulse in an older patient, and other pulse points may also need to be considered. Blood pressure also tends to be higher in older patients, and cap refill is not a good assessment because of skin changes and reduced circulation to the skin. All right, under reassessment, on the bottom of page 1303, you want to reassess the geriatric patient, often because the condition of the older adult may deteriorate quickly. You want to recheck interventions. You want to allow the patient to maintain a position of comfort unless contraindicated, and you want to assist ventilation as needed. And you want to administer glucose for a patient with diabetes who have altered mental status and a manageable airway. Oxygen may be a useful therapy for many geriatric patients. And listen to your patient, respond to your patient, and provide reassurance. And lastly, you want to document all history, medication, assessment, and intervention information. And I'm going to take a break, and I will be right back.